I apologize for the late because some glitches are there technical. Welcome to all. Today we have our esteemed panel to discuss managing HCC with portal vein tumor thrombosis, navigating the gray zone. We have with us Dr. Rohan, Dr. Devinder, Dr. Hira, and Dr. Ajay Yadav. We will walk through a single case that truly highlight the multidisciplinary decision making, how we transition from the surveillance to the loco regional and systemic strategies, and where curative intent still fits in. This is our case. This is a 66-year male, diabetic and hypertensive for 8 years. He had his first variceal bleed back in 2018, underwent endoscopic variceal ligation and remained compensated thereafter. For nearly 5 years, he stayed asymptomatic, no secondary prophylaxis, no other compensation. In 2024, he presented again with another variceal bleed managed with EVL and was still otherwise compensated. Here, I would, unfortunately, Dr. Sheetal is not here, so apologies, sir, Yogesh sir. So I have to ask a few things to you, sir. Sir, would you routinely perform 6-month USG and AFP surveillance in such a patient with NASH? And what are the barriers to implementing this in real-world Indian practice? Can we have mic? Sir, please on that, sir. Sir, please, if you don't mind, sir. Okay, yeah, fair enough. Yes.
Ideally, we should do a 6-monthly ultrasound and alpha-fetoprotein. Unfortunately, we are not able to do that. Either the patient is not compliant with it, and we also don't have a very good follow-up program. In the ideal situation, we are not working in that. So if possible, one should follow up these patients. My suggestion is that we should move into the Gallard score or GAD score, which predicts which patient is more likely to develop HCC in the future. But this has not been very popular in India as yet, but we must move on to that.
Okay. Very well said, sir. Thank you. This imaging now reveals a well-defined lesion, roughly 6.8 into 5.4 into 6.2 centimeter, involving segment 6, 4th and 8th, and extending into segment 5th, with clear evidence of right portal vein tumor thrombus. There is no extrahepatic disease on FDG PET. So radiological, the enhancement pattern favors a tumor thrombus rather than the blunt thrombosis. So, Dr. Hira, we have Dr. Hira, that IR specialist in our hospital. So, considering segment 4th and 8th involvement with the right portal vein thrombosis, what are the technical determinants for tear, dosimetry, and catheter positioning to avoid non-target radiation? Yeah, it's working.
So in this, this is a complex case where you can see segment 4 and 8 are involving with right PVTT. That means when we do dosimetry, it is increasingly important that you avoid non-target radiation. So for that, first we have to do DSA to see the arterial anatomy, and then tear part 1, or also called technetium 99 MA planning. In that we see what is the uptakes in the lung and in other part like stomach, pancreas, and normal liver parenchyma. So arterial anatomy, and then we also see, because there is right PVTT, so we see if there is any artery which is same supplying the PVTT, right PVTT, and also the tumor. First is then we do DSA MA planning, and after that we do the dosimetry. In dosimetry we use partition models where you calculate the tumor volume and the normal parenchyma, and then calculate the dosimetry. And also when you do MA planning, you stimulate that from where you want to give Y90. So segmental and super selective selection is important, where you're using microcatheter, and avoid the normal parenchyma and the other branches, where you can also, if there is some non-target radiation, you can embolize them using coil or uh, temporary particles or gel form, so that
Okay.
you can avoid that.
So, or do you embolize shunts prior to yttrium 90 infusion in such cases, if any shunts are there?
Yes, if the lung shunt is high, then 20%, then we have to embolize the shunts using coils.
Okay, fair enough. So these are the lab investigations, fairly under normal limits: hemoglobin, platelets, bilirubin, and INR, and AFP 12,440. Overall, Childbug A6, ALBI grade 2, and Karnofsky 90, and BCLC stage C. So this is a classic case with compensated liver, excellent performance status, but biologically an aggressive disease. So putting all together, compensated NASH-related CLD with portal hypertension with residual varices, a large HCC involving segment 4th, 8th, VP2 level portal vein tumor thrombus and MELD sodium 10, ALBI2 and Crefitae 2 and BCLC-C performance status was 0. Comorbid diabetes and hypertensive, but functionally fit for aggressive management. So keeping all these things in mind, uh, just Yogesh sir, do you believe BCLC C1 capture the biologic diversity of the portal vein thrombosis cases, or should we incorporate Crefitae score ALBI for better functional stratification in these cases?
I think the biological diversity is indicated by the presence of PVTT, and ALBI score should be utilized in these cases because the prognostication would tell the higher the ALBI score, more are the chances of response or non-response. So I would say ALBI is very important, and certainly the patient has an aggressive tumor.
Yeah.
It indicates that.
Thank you, sir. To Dr. Rohan, with MEL10 and ALBI2, would these patients have been a candidate for curative intent trial resection or LT after downstaging under APASL modified criteria?
After downsstaging, we will first look at the liver remnant, and depending on that, we can. Well, now there are few centers who do curative intent resection by doing thrombectomy after the tumor thrombus becomes bland, and then doing portal vein reconstruction. But in our setting, what we are doing is, in such cases where we see VP3 to tumor thrombus, we will do tear plus SBRT, wait for some time, wait for downstaging, and if downstage at 8 weeks to 12 weeks, we will offer liver transplantation. So yes, such candidate we will offer transplantation.
So these are the treatment options. NASL guideline lists several options here: tear or SIRT with yttrium 90, SBRT plus minus stays, immunotherapy with atezolizumab, bevacizumab or striate, resection in selected cases, and liver transplant. So our focus should be on defining which path offer durable disease control while preserving hepatic reserves.
I have another comment to make in the previous slide. So there are centers which are doing TASTE plus SBRT. In TASTE plus SBRT also they are achieving good downstaging compared with TARE with SBRT. But TARE alone as a modality for downstaging in such a case, you would not achieve adequate downstaging in the limited number of time period. So a combination of TARE SBRT or TASE SBRT followed by addition of a TKI in such a case would allow the patient to reach resection or liver transplant.
Definitely. So to Dr. Rohan. So, technically resectable portal vein thrombosis in your practice, what exactly it is, and would VPT involvement in right portal vein preclude resection?
So in non-cirrhotics with HCC and portal vein tumor thrombus VP2, yes, we will still give some kind of downstaging like a TACE or SBRT or a TARE. But there are centers who have directly gone for resection first, and but we have to have some evidence in that. So technical resectable PVTT would be a case which is child A, where a future liver remnant is more than 40 to 50%, and where the ECOG status is good. So up to VP2 tumors, yes. So these are resectable.
Can I interrupt?
Yes, sir.
I think if you have PVTT, I won't do an upfront resection.
Yes.
There is good data now actually. Even in resectable without PVTT, if you do neoadjuvant TACE and start them on TKI and then do resection, actually recurrence-free survival is much better. So if you have somebody's got PVTT, especially VP2, so it is better to do some sort of neoadjuvant therapy before considering them for resection if it is otherwise resectable.
So I would think like if it is a peripheral tumor with a VP2 thrombus with a limited resection, yes, directly go upfront resection. But in followed by adjuvant TKI or some adjuvant because it's a macrovascular invasion.
So the point I'm saying, Rohan, is not to do that. Do a neoadjuvant therapy and resect. There is good data actually now. There are very good papers actually on doing neoadjuvant therapy and then resecting, especially in the presence of tumor thrombus. Any tumor thrombus, actually, you should do neoadjuvant therapy and then resect them. So that will be either TACE along with TKI and then resecting them. That you can do it. Technically, it is possible, but the aim is to achieve a long-term recurrence-free survival, which will be better with this therapy.
So, due to the time constraint, I have to skip certain questions. So, Dr. Hira, how do you handle arterial flow steal in NASH-related cirrhosis? Is pre-tear coiling of collaterals always necessary?
So during MA planning, you see that if the artery where there is steel, you go distal to it in the branch where the artery which is supplying the tumor. If you are able to go into that artery, then the coiling is not necessary. But sometimes the arteries are small, you are not able to go into tumor feeding artery, so you have to coil then that the dominant non-filling artery.
Very well said. So our patient underwent Y90 tear. At 2 months, AFP dropped dramatically from 2440 to 480. There was partial recanalization of the portal vein thrombus and partial response in the targeted lesion by RECIST criteria. So we achieved biological and radiological downstaging of this tumor. So again to Dr. Hira, what imaging criteria confirm true portal vein thrombosis necrosis post tear? Is contrast fill in at 4 to 6 week a reliable marker?
No, because sometimes if the tumor is even non-viable, but because of the vessels permeability, still you can see contrast there. So important criteria after 4 to 6 weeks is one is a PET. If there is before the tear, if there is avid, and post tear if is not avid, then definitely that is the reliable marker. Another is dual CT where you can see the iodine contrast uptake and persistent arterial enhancement.
To Dr.
So I have a comment to make. So PVTT we have made very. We will see portal vein expansion. We will see enhancement of the thrombus. We will see new vascularity, and it will be contiguous to the tumor. So post tear, supposedly after, if we do a scan very soon, so we may see some enhancement. Would that be a residual tumor requiring extra SBRT, or will it be fill in?
If you do any imaging less than within 4 weeks, no imaging can tell you we have blood or not. So we have, that's why we always follow after 4 to 6 weeks, not within, because some inflammation also can enhance.
So initially, when we were doing this, we were adding, seeing this enhancement at 6 weeks, and we were giving extra SBRT to the tumor thrombus. But later we found that if we wait for more time and do another imaging after 4 weeks, this fill-in will go on. So
That's true.
it can be either radiation hyperemia or some inflammation.
That's true, because
post-tear.
post-tear there can be inflammation,
So
which
one
is
should-
mimic the
So one should wait for at least 4 to 6 weeks to re-image the tumor to assess the exact categorization of that tumor. So Dr. Devendra, when exactly you want to take up the patient for the resection after tear, and between anatomical versus non-anatomical resection in a post-tear parenchyma, what is your preference?
So after tear, the maximum tumor necrosis, it takes around 6 to 10 weeks. So we should wait at least 6 to 10 weeks to achieve the tumor necrosis. However, at the same time, if we wait more than 10 to 12 weeks, the radiation induced changes like the perivascular fibrosis or parenchymal changes, they may take effect. So the timing is around 8 to 12 weeks, where we should consider resection. And to the second question, whether we should do anatomical or non-anatomical, same post-radiation changes in the form of capsular retraction or color changes that may make a non-anatomical resection oncologically not sound, because we will not be able to clearly make out the margins. So it would be preferable both oncologically and technically to go for an anatomical resection.
So, to Dr. Ajay Yadav, given AFP response, is there a role of maintenance TKI, or do you want to hold until progression?
So there are some studies where combination of tear plus lenvatinib has been shown the better PFS, and it should be continued till progression.
Okay, fair enough. So, continuing our case, after partial response, what are the available options which are remaining with us? Is the second loco-regional session, SBRT or TACE, surgical resection, transplant consideration, immunotherapy with etijo, beva, or stride or systemic TKI such as lenvatinib. This is where exactly the multidisciplinary sequencing becomes critical. Each option affects the next. The patient was started on lenvatinib. After 3 months, he developed ascites controlled on diuretics. AFP rose from 480 to 2450. A new lesion appeared in the left lung, clear evidence of a progression. So now we are facing extrahepatic spread, but still relatively compensated liver. So, to Dr. Ajay, in Reflect trial, patient with portal vein thrombosis VP1 MO were excluded. Is of label lenvatinib in AVP2 empirical or evidence-backed? And would you consider early switch to etijo-beva or sequential combination, that is the lenvatinib plus PD1 in a controlled ascitic settings?
So problem with etijo plus bev is that there are chances of bleeding. If patient is having bleeding, then this combination is contraindicated. If bleeding is not there, then it can be given. In this situation, it can be used in second line if bleeding is not there.
Okay. So following tear and lenvatinib failure, options now include SBRT with or without TACE, with or without ablation of the lung lesion, immunotherapy with etijo-beva or stride, and second like TKI like sifogenlatinib or regorafenib. So to Dr. Ajay again, would you consider SBRT to the liver lesion or stereotactic ablation to the lung nodule to resect systemic therapy response?
yeah, if it is there is good response and there are some lesions, then we can use it.
To Dr. Devinder, if he achieve complete response, would you revisit transplant or resect in this patient?
So, if patient achieve complete radiological response, then again we should prompt ourselves to look for further cure. And literature also suggested that the patient who achieved complete radiological response and who underwent resection further, they had better 3-year survival compared to patient who were left out.
Okay. So the
With a lung mate, are we discussing transplant?
no, we will discuss. Actually, we are unfortunately we are running out of time, so we have to
With a
squeeze
lung
questions.
met, even after giving radiation, transplant should not be offered, I think.
So we'll discuss in further 2 or 3 slides. The patient was switched to atezolizumab after 2 months and 3 doses. AFP fell again from 2450 to 760 with stable disease, radiological. So biological control has been regained. So to Dr. Ajay, how long do you continue atezolizumab in stable disease by RECIST 1.1 or clinical tolerance criteria?
So if patient respond, it should be continued till progression or intolerable toxicities.
To Dr. Yogi sir, how do you differentiate immune hepatitis from HCC related hepatic flare in this scenario? Role of transaminase pattern or biopsy?
Transaminases would not help. Immune hepatitis would have higher levels of globulin and IgG, something that behaves very much like autoimmune hepatitis. Biopsy may be indicated in such cases because with autoimmune, like features with immunotherapy, just 4 to 8 weeks of steroids is good enough. Not so with autoimmune, which gets precipitated.
Yeah. To Pamecha sir, for response to atezolizumab, do you see any role of salvage resection or transplant once AFP goes down below 200 and portal vein thrombosis resolved?
Okay, so now in this index case, obviously, if the problem here is lung met actually now. So I would have thought he should, the way it will be, he should receive good immunotherapy for a good duration actually. And then if he is stable, and then obviously after immunotherapy, anyhow you need to wait at least 3 months before you can transplant them. So in this index case, I would have waited, maybe 6 months and see. And if there is no progression and AFP remains below, and in a given case, who has got a live donor available with them. So I don't know, in a stable, no progression, single lung met, which is very small as well. I don't know whether you can offer transplant. It's a discussion between the patient and the team, and if they got a donor and he's got a good response to immunotherapy, there may be a case to offer it. Because long term actually will depend on he's decompensating now, so he doesn't have much option in local regional therapies now. Okay, so, and in a short duration, he won't be eligible for any systemic therapy as well.
So, thank you, sir. Very well said. So we have to. One should wait for at least 6 months and long to see the progression or whether the disease is stable. So early surveillance in NASH is essential. Portal vein thrombosis is not an automatic contraindication. Atrium 90 and conversion surgery are changing the paradigm. Biologic response markers such as AFP, kinetics, and portal vein recanalization can redefine candidacy for curative therapy. And finally, true progress lies in multidisciplinary collaborations where hepatologists, intervention radiologists, oncologists, and transplant surgeons align rather than sequence their efforts. Thank you very much, everyone, for bearing me, and because we have to squeeze all our questions because we are running out of time. Thank you very much. We have to gather upstairs for the inauguration. Sir, it's still the patient is in that waiting period of 6 months. So we are waiting. If God is great, then we can offer him, and I will let you know, sir. Yes, sir. Sir.
biopsying such a small nodule will be very tough.
So we have many times we have done a
Wedge resection.